Just give me a minute. Okay, is the other two groups ready to answer the questions?
Yep.
Okay.
Yes, we're ready.
I had some other questions at the beginning, right? Okay, what was the answer for this one?
3.
Our group went with number 2, initiate IV therapy, because they are likely going to need fluids when you have septic shock, and you can't give the IV antibiotics until they have an IV started.
Okay, very good. So initiate IV intravenous therapy is the right answer. The next question was, how would the nurse best explain a blood glucose level of 250 milligrams per dl to the family of a non-diabetic client in septic shock?
Number 3, the value reflects the body's attempt to respond to stress.
The values, yes. So that is the right answer. The value reflects the body's attempt to respond to stress. So because a client who is in shock will exhibit a stress response. And the high glucose is a result of what? Glycogen conversion by the liver. Question 3.
Three.
What was the answer?
3.
3. Fluid resuscitation requirements diminished.
Well, we had discussion about that because the question asked what assessment finding, and in order to assess that they need less fluid, you would be looking at their blood pressure stabilizing as well as their output increasing. But with sepsis, blood pressure is a more important finding than urine output. So our group would discuss this through and thought that the fluid resuscitation is an outcome, not an assessment.
I don't know. We put number 2, so.
Yeah, the book talks about blood
Let
pressure.
me read the rationale, because this is from straight from your textbook and they have the rationale. Okay. Usually the first sign of improving status is a reduction in the amount of fluid resuscitation required. Next, blood pressure stabilizes and then urine output improves. Blood cultures may be normal within 48 hours of starting antibiotics, even though the inflammatory process continues to cascade.
Okay, so just so we understand it better, what determines the fluid resuscitation requirement?
Yeah, you have to
because
have
I was
in order to
I've
determine.
always assumed that typically whenever you have a patient that is is showing signs of sepsis, they do a bolus, then they recheck the blood pressure to determine if they need more fluids. So I don't know. I feel like they go hand in hand, but the assessment portion would be the blood pressure, not the actual fluid resuscitation.
They go hand in hand. The blood pressure stabilizing within normal limits won't be the thing there. It doesn't go back to normal limits with the even if you are what was that being treated for sepsis is improving when which assessment finding is evident. So they are in the improving stage. It is not like completely treated. Okay.
So what show I just don't understand what shows the fluid resuscitation requirement is diminished. then if it's not these assessments?
So for me, I think I just figured it out in my head. So answer choices, answer choices 1, 3, and 4. I'm sorry, 1, 2, and 4 are all normal, but 3 says the requirements diminish, and the question is asking, showing improvements, not
That's
cured.
yes, Megan. That's exactly what I was going to say. Thank you.
Okay, it just
This-
it like clicked in my head.
Yeah, within normal limits means the blood pressure won't go to 120 over 80 or 130 over 60, even though the patient is recovering from the shock.
Right.
Okay, that makes sense.
Yeah. So if
Sometimes I have to look and see like what makes this answer choice stand out amongst all the other ones, and that's what it is.
Yes.
Because in the question it's asked, we got hung up on the word assessment, but if you look at all the other answer choices, it's all normal, perfect world.
Yeah, you're
versus
right. That's one of those
3.
weird questions. It's a trick
Yeah,
question. I hate
yeah.
See
Well,
that?
we've been
Less of
taught.
those on the NCLEX because
Yeah.
I suck at these questions.
I know.
Because we get hung up on assessment. Like we're doing the testing strategies by looking at what they're asking for, but then we get hung up. So it's just like, it's hard.
Yeah. See that's why I had highlighted this within normal limits, because
Yeah.
those are the things that you will be looking. Okay, 30
Normal,
ml per
normal,
hour.
normal.
Yeah, you won't get a 30 ml per hour urine, even if the patient is recovering from the shock. Okay, it will take time for them to go back. If it will take time to completely recover and go back to that 30 ml per hour limit.
Right.
All right, good. And thank you, Megan.
You're welcome.
I'm almost done.
It just clicked.
Yes. And that will help you in your longer run for the NCLEX and HESLA.
It's
Okay.
like one of those things. Like every answer choice is right, but which one's most right?
Right.
So you learned something at that seminar we went to.
Yeah, exactly.
It wasn't a waste of time.
Did you go for a seminar?
With Miss
Last
Simmons,
semester.
we did. Yeah.
Oh, yeah, I know. The NCLEX prep, right? You will get another seminar at the end.
Yeah, like test taking strategies type of thing.
Yeah. Okay, so the case study. Let's move on to the case study. Physical examination. Okay, can you just say what the case study is about for the other two groups, please? Anybody?
I mean, she's pretty much in multi-organ dysfunction. She's requiring continuous renal replacement, which is CRT, because she's in kidney failure. And yeah, we basically just outlined all the goals and the interventions for
Okay.
her.
So what is MODS?
Multi-organ dysfunction syndrome.
Okay, very good. And after reviewing WA's presentation, what organ system do you suspect are involved and why?
We said renal system because it talked about all of her electrolyte levels and as well as like her urine. And then we talked about her respiratory system because she had crackles and she was requiring oxygen and was still satting low. Her GI system, she had hypoactive bowel sounds, and then the cardiac system, was her blood pressure was elevated as well as her pulse for that.
And neuro.
Acute changes in the neurological status with confusion.
Oh yeah, we forgot that.
Yeah. Okay, so that was it. That was the things that were affected. So what was the other question? What do you think is the origin of WA's septicemia?
Hemodialysis.
You don't have that question, right? What is the other question that you have? What are additional tests would you anticipate for WA?
We said like APD, yeah. AB for her hypoactive bowel sound, and for like a CT of the abdomen.
Okay.
Blood cultures,
Bleeding times?
PTI, all
Yes.
Mm-hmm. Chest X-ray, ultrasound for the kidneys, and AccuChecks every 4 hours.
It looks like from her UA she may have a UTI, which in addition to her decreased kidney function may be what sent her over the edge. So urine infection.
Urine function. Very good. What are the interprofessional care rules for WA?
Tube oxygenation.
Okay. First, you have to know where the underlying infection is and treat the underlying infection. And
Fluid balance, eyes and nose, daily weights, possible
These are the interventions. I think we're still doing care goals.
maintenance of tissue oxygenation.
Oh.
Providing nutritional and metabolic support. And appropriate support of individual failing organs. Because there are more than one failing organs, right? So, individual support for those failing organs. Describe interprofessional care that would be appropriate for WA.
Respiratory.
Okay. Respiratory.
that would be like all the respiratory, so the daily weight, strict diagnosis.
But what is the
Respiratory therapy was supposed to be care team that you were talking about, right? Is that the question we're answering?
the interprofessional care? Yes.
Intervention.
Oxygenation. How will you maintain oxygenation for WA?
ventilation.
Keep the face mask on, like 15 liters. So make sure that
Why don't you go there in ICU and do ventilation?
you should get
Mm-hmm.
She needs mechanical ventilation for oxygenation and ventilation. Yes, she needs mechanical ventilation. Infection. How will you treat her infection?
antibiotic.
Yeah, broad spectrum IV antibiotics. Nutrition and metabolic support.
Probably gonna be on like
TPN
TPN or enteral feedings.
with sodium restriction.
Okay.
Well, she's hyponatremic, so do we sodium restrict or fluid restrict?
Sodium.
You don't need to restrict anything. You just put her on TPN or enteral feeding for nutrition and metabolic support. Her blood glucose. What happened to the blood glucose?
It was already
High. So you have to bring that down.
Insulin drip.
IV insulin. Then she has
Hyperkalemia.
hyperkalemia. How much was her potassium?
16 mil.
Hyperkalemia. Well, how will you reduce the potassium? And it is very important to reduce the potassium because otherwise she is more at risk for disrespect, right?
Diuretics. Lasix.
That is shock, right?
Huh?
She is in shock.
Yeah.
If you give diuretics, what will happen?
She'll bottom out.
So you cannot give diuretics for bringing down the potassium. It will basically constrict
Will it be addressed with her dialysis?
it is fixed, right? Her BUN reaction, if everything is in place, then yes, they will do the CRRT. Okay, continuous, renal replacement therapy. But otherwise, they will just give her the insulin can take care of that.
Right.
The insulin will bring down the capacity.
And what about KXA?
KXA you can give KXA to bring down the capacity. Now, support for individual organs, kidney, hemodialysis, if she's in ICU, yes, CRRT. Cardiovascular, continuous cardiac monitoring, vasopressors, hemodynamic monitoring. Then, VTE prophylaxis, breath work, and low molecular weight retention. Okay. Coming down to this, WHO in October, the past 4 hours of 28 hours, why would CRRT be ordered for WA?
CRT is kind of like an emergent renal replacement. So when the kidneys aren't functioning and doing their job, especially like an AKI, then typically they would go to the ICU and be put on CRT to kind of speed up the process of fixing those levels. And
You're removing the fluid from the plasma.
Okay. So to protect the further damage of kidneys and to maintain fluid electrolytes and acid-base balance. Okay, outline a plan of care for CA. We already said oxygenation. She is on ventilator. When she's on ventilator, you have that. What are the nurse's responsibilities?
Check the PEEP.
Check the PE. What else? RT will check the PEEP, but keep an eye. If the PEEP is increased, they are more at risk for what?
decreased cardiac output.
The collapse of the lung.
Yes.
The name you gave me in yellow.
Volume trauma.
Mhm.
Trauma.
Oh, barotrauma.
Yeah. Okay, so perform ABGs, monitor ABGs,
Oral care,
oral care,
comfort measures, positioning, analgesic.
always 30 to 45 degrees at elevated. Pulmonary hygiene, suctioning with aseptic techniques. And fluid volume, strict INOs, administer ordered IV fluids and nutritional replacement therapy. Tissue perfusion, monitor vital signs, maintain continuous ECG and hemodynamic monitoring.
Mm-hmm.
Look for stress ulcer points, and now I'm answering all the questions. Alright guys, so that's it.